Hi, Susan, is my audio working okay?
Yeah.
I can hear you.
Right. Okay, looks like we have all the board members. I will call to order the Green Mountain Care Board's hearing of May 1st, 2024. Two agenda items today. One is a discussion of a draft of affordability standards or measures that the board has put together, and we've received a lot of public comment on. That's been very helpful. So Mike Barber will have a discussion of those standards. And then we have our ongoing discussion about the AHEAD model and global budgets. We have no minutes for today. We'll do those next week. So I'll turn to Susan Barrett for the Executive Director's report.
Thank you, Chair Foster. We have a few public comment periods going on right now. As a reminder, they're all located on our website under the public comment tab. And the first one is the board is accepting public comments on a proposed revisions of the reporting manual for Vermont's all-payer claims database. And we're accepting those comments through May 31st of this year. You can see the proposed draft online at that public comment portal. In addition, we have two ongoing public comment periods. One is regarding community engagement and the work around Act 167 and hospital sustainability. Please share any of your comments regarding that work. And then also regarding the next potential all-payer model, the AHEAD model. Any of the comments we receive on that, we share with our partners at the Agency of Human Services. And then I'd like to remind the public to please keep an eye on our monthly meeting and our agendas. We are maybe adding some meetings in May. It's a very, very busy month. So we will add those as needed and obviously put that and notice it on our website. And please let me or Kristen know if you have any questions regarding that. And with that, I will turn it back to you, Mr. Chair.
Thank you. So the affordability guidance and standards that we put together were part of our effort here at the board to continuously improve all of our regulatory processes and understanding of our system. And Mike and his team have worked really hard to come up with a potential methodology for us all to think about. Understanding affordability of our insurance rates is critically important at this time in Vermont. It's always been important. And it's particularly important now because of the large increases we have. And so this is an effort to understand how we as a state are doing in terms of affordability. And so there's been a lot of effort put in to do that. And I think it's been really valuable to go through that exercise. And Mike will provide us an update as to where we are. So thank you, Mike.
Thank you. I'm just trying to load the slide deck here. Just give me a minute. Can you see the first slide?
Yes.
Great. So good afternoon. For the record, Michael Barber, Board's General Counsel, here today to talk about the draft, a draft rate review guidance document relating to affordability. Going to start off with some background. As you know, in reviewing major medical health insurance rate filings, Vermont law requires the board to determine whether rates are affordable, promote quality care, promote access to care, and protect insurer solvency. Vermont law also requires the board to determine whether rates are not unjust, unfair, inequitable, misleading, contrary to law, excessive, inadequate, or unfairly discriminatory. The board has consistently observed that these criteria are interrelated and often in tension with one another. And I think that owes in part to the fact that a rate is just a number, and these factors are a lot to put on a number. Again, as you know, there is what I would call an analytic framework in place for determining whether proposed rates are excessive, inadequate, or unfairly discriminatory, and whether they protect insurer solvency. The actuarial standards of practice define these terms, and there are, well, most of them, and there are actuarial opinions and solvency opinions that are kind of built into the rate review process. There is no similar analytic framework, however, for determining whether a rate is affordable, or for that matter, whether a rate promotes access or quality or is unjust or unfair. And in the absence of such a framework, the parties to rate review proceedings typically present evidence and arguments based on competing views of affordability. So the carriers might testify, for example, that you need to view affordability in terms of what the alternative is. So is it more affordable to be uninsured and to pay for your healthcare needs when they come up? Carriers might also emphasize how much of the premium goes to pay for the cost of care versus the cost of providing insurance. The Office of the Healthcare Advocate, on the other hand, typically presents a more consumer-oriented view of affordability. In the past, they have presented some calculations in their post-hearing brief, comparing premium growth to wage growth and comparing premiums and deductibles to standards found in the Affordable Care Act for premiums and the Vermont Household Health Insurance Survey for deductibles. So it's worth talking briefly here about the MVP case. It was mentioned in several of the comments, which I'll get to in a minute, and it is relevant. This case arose out of the board's denial of a rate filing from MVP. The board had denied the filing on the grounds that the proposed rates did not promote access to quality healthcare and were unjust, unfair, and inequitable to plan members. MVP appealed, and one of MVP's arguments on appeal was that the statute unconstitutionally delegated legislative authority to the board because it didn't provide sufficient concrete guidance as to the meaning of the terms affordable, promotes quality care, promotes access, or any direction as to what evidence to consider when making those determinations. The Vermont Supreme Court rejected MVP's argument that the statute is unconstitutional. It reasoned that by directing the board to consider affordability, quality, access, solvency, and fairness, the statute sufficiently curtailed the board's discretion. And the court noted that the general and open-ended nature of these terms, quote, reflects the practical difficulty of establishing more detailed, narrow, or explicit standards in this field, a difficulty due to the fluidity inherent in the concepts of quality care, access, and affordability. Accordingly, the court wrote, flexibility is needed to accomplish the legislature's goals of universal access and coverage, cost containment, quality improvement, and so on. But while the court upheld the constitutionality of the statute, it nevertheless reversed and remanded the decision to the board because the board had failed to adequately support its conclusions with specific findings based on the statutory criteria. The court found that the board's explanation of its decision was simply too sparse to show how the facts supported a denial of the rate filing under the statutory standard. And it emphasized that the clear application of standards is necessary and adequate findings of fact are required so that the Supreme Court can determine whether the sound discretion implicitly mandated by a statute was actually exercised by an agency. So moving on, in August of last year, we learned that the Commonwealth Fund was offering technical assistance to states to design, implement, or refine commercial market affordability strategies. We applied for assistance and we were accepted, and through that program, we were able to work with Baylor Health and the Center on Health Insurance Reforms at Georgetown University. One of the first things that they helped us do was, look at what other states are doing with their rate review programs on the issue of affordability. We didn't find an instance of another state incorporating an affordability definition or metric into its review of health insurance rates, despite, some statutory language that might suggest otherwise. But we did find that agencies in a handful of other states are requiring insurers to implement policies designed to control cost growth and lower premiums. So Rhode Island is the kind of the prime example here, but Delaware has done this recently as well. And in general, these policies that insurers are being required to implement involve limiting price growth for hospital or non-professional services. I think that is being expanded in Rhode Island actually to professional services, by pegging them to inflationary indices in some way, increasing investments in primary care and supporting primary care transformation, and increasing the adoption of alternative payment models and population-based contracts. I've cited an article here that describes this kind of state landscape in a bit more detail in case you want to look at it. One of the authors, Sabrina Corlett, is someone who we consulted with on this project. She works at the Georgetown University's Center on Health Insurance Reforms. So, when I looked at that, kind of what other states are doing, it seemed to me that as a state, we already do a lot of these things outside of the rate review process. For example, the board limits price growth at hospitals directly through the hospital budget process, where it might be more broadly impactful, I think. And in this year's guidance, the board adopted a price growth target that's tied to the PCE price index. The state supports primary care transformation through the Blueprint for Health, and there's a focus on primary care investment through the ACO and the all-payer model. And finally, the state has tried to increase the use of alternative payment models and population-based contracts through the all-payer model, although probably with less success than I think we'd all like. It also struck me that the approaches or strategies that are being implemented by other states through their rate review programs all very much seem to relate to the AHEAD model. And so we didn't feel comfortable kind of going off on our own and trying to pursue one or more of these strategies through rate review. And if we had wanted to do that, it would likely require rulemaking, and so it would be a longer term project. We did think, however, that we could try to develop an approach or a framework for determining whether rates are affordable, understanding, of course, that affordability is just one of several interrelated factors, as I mentioned earlier. And so that's where we focused our efforts. And really, it was Jeff Batista here at the board who led this aspect of the work. And so I'm at a bit of a disadvantage because he's no longer here, and I'm trying to sort through the technical aspects of this. In addition to being useful for the board's review of rates, I think there was a hope that work in this area could have some relevance to the hospital budget process, or could simply help inform the public or legislators or others working in this space about the affordability of rates. I should also say that we focused our efforts on the individual and small group rates Because large groups are experience rated, we don't have good insight into what the premiums actually are. And, there were other complicating factors that we just couldn't work through in the time that we had. So a draft guidance document was developed along with a data template for carriers to complete during the rate review process. Both documents were sent to interested parties to review and provide feedback. We also posted the draft guidance on our website and sought comments from the public, although we did not receive any public comments. I won't spend a lot of time talking about the initial draft because I'm going to focus on the revised version that's posted. But what I think is important to understand is, in very general terms, the initial draft was trying to tackle two big questions. First, what rates are affordable? And second, where proposed rates are unaffordable, what will the board do? And on the question of what rates are affordable, the initial draft included two standards. So a premium affordability standard taken from the Affordable Care Act and a deductible affordability standard based on the Commonwealth Fund or the Vermont Household Health Insurance Survey's definition of underinsurance, a portion of it. It's a broader definition than just the deductible, but there is a piece that's focused on the deductible. I shared the comments that we got with you all. I'd say we got some pretty strong pushback on the initial draft. I don't think that all the concerns that were raised are valid, but for a few reasons, I do think it would be wise to take a step back and consider something a bit more modest this year, modest in scope. And so that's what I tried to do. I tried to make some revisions to the draft for you to consider. The primary revision being a more limited scope. So the aim of the revised draft would really be to get better information into the record on what affordability looks like from the perspective of an individual, so that you could consider that in your decision making. And I think that more limited scope can really be understood as a continuation of efforts that began last year when you asked Lewis and Ellis, the board's contract actuaries, to provide some data relating to affordability and, in particular, net premiums. I also tried to include some language in the revised draft to allay concerns that were raised in the comments. So specifically, the revised draft is clear. I hope that the required contribution percentage, so that's the ACA, Affordable Care Act standard, that's being used as a point of comparison and should not be understood as a rate cap. Language was also added to state that the guidance should not be interpreted to prevent the parties to a rate filing from presenting other evidence and argument on the issue of affordability, or from presenting arguments about what weight the board should give to the information that it collects. So, for example, the healthcare advocate may want to present arguments about how a rate increase compares to wage growth, which, as I said, they have in the past. And you might find that information helpful and valuable on the issue of affordability. Similarly, the carriers may want to emphasize their cost of insurance as it relates to affordability. And again, you might find that information helpful as well. And this guidance wouldn't foreclose these kinds of presentations. The evidence that the board collects from the carriers under this guidance would not be the only evidence that could come in or be relied upon by the board. The revised draft also makes some adjustments that were suggested in the comments, and we would plan to revise the reporting template to address a few more. So I'll spend a few minutes going over those. First, you'll notice that while the initial draft called for submission of data regarding standardized plans, this revised draft requires submission of data on all plans. This was a suggestion made by the healthcare advocate, and it made sense to us. Second, you'll notice that the revised guidance doesn't require carriers to submit information on how the deductibles for their plans compare to the 5% of income standard for underinsurance. And so there's a lot going on here. In its comments, the healthcare advocate had raised questions about how the board would deal with different kinds of deductibles. So stacked versus aggregate deductibles and combined versus separate medical and pharmacy deductibles. The healthcare advocate has suggested a way forward on, how to deal with plans with separate medical and pharmacy deductibles, which was simply add the medical and prescription deductible together and compare that to the 5% standard. But they didn't suggest a way forward on the stacked versus aggregate deductible issue. And it's really the stacked deductibles that are the issue. And I honestly didn't know how to deal with that and still include all the plans in this analysis, as I just talked about. So just to clarify, with an aggregate deductible, it's the family has to meet the family deductible before the plan pays any benefits. And with a stacked deductible, the plan pays benefits to each member of the household who meets an individual deductible, and then to any household member once the household meets the household deductible. That's how I understand it works. The HCA said that when it examines affordability, it has only looked at the affordability of plans with an aggregate deductible. So I went ahead and looked at how many plans have these kinds of different deductibles. And so for the 2024 plan designs, there are 10 plans with stacked deductibles and 9 plans with aggregate deductibles. So it is a big issue. And then the carriers and our sister agencies raised concerns with looking at deductibles at all as a measure of affordability when the deductibles are kind of already set for this year and are largely dictated by federal requirements, and where whole metal levels of plans will kind of by definition fail the test. So my thinking kind of was that with the more limited scope of the revised guidance, it made sense to take out the deductible piece. And if the parties wanted to address deductibles or cost sharing and how that related to affordability, and they had a good way to do that, they could try to do that through the process. So I'll come back to that in just a minute, but kind of moving on, the third change here is that the revised guidance would require carriers to provide information on premiums for their current plans, their in-force plans. So in other words, 2024 premiums rather than proposed 2025 premiums. Both the healthcare advocate and MVP expressed concern with analyzing proposed premiums. And that's because we're trying to account for premium assistance, which depends on what the final rates are. And so there's a lot of circularity there. So the change, I think, makes the information accurate, but maybe a little bit less relevant. And again, the parties could argue about the weight you should give it. Fourth, I'm proposing that we adjust the data template that we shared initially to reflect the Medicaid income eligibility threshold of 138% federal poverty level. This was an issue raised by both the healthcare advocate and Blue Cross. So basically the income brackets that we would be looking at would start at 138% FPL instead of 100% FPL. The guidance document doesn't go into that level of detail, and so that didn't need to be adjusted. but we would plan to revise the data template. And then lastly, we would adjust the data template to reflect that the patient share amount can't be below 0. This was another issue raised by the HCA. And again, the guidance document doesn't go into that level of detail. There were several other kind of technical issues raised by the healthcare advocate in its comments that seemed either too complicated or not worth pursuing right now, but perhaps could be addressed in the future. The revised draft is posted on our website. The data template is not, it's still under revision, but I don't think you need to vote on that. So we have a little bit of time on that piece. There is a potential vote scheduled for next week, which is soon, I know, it's very soon. But the idea was to have something in place before the filings come in on May 13th. I did share the revised draft with, the same stakeholder group that I shared the initial draft with. I did hear back from the healthcare advocate, but none of the other stakeholders. Eric Schulteis reached out to me yesterday to tell me that they are opposed to it. I think their opposition is both to the revised scope and the removal of the deductible analysis, and maybe some other pieces as well. I'm sure Eric will explain that to you. I stand behind the revised scope. I don't think we're quite ready to define affordability by reference to data that we've never received before. And I think it makes sense to get the data first, see what it looks like, see how useful it is to you, if you find it useful in your decision making, before we kind of lock it in as this is what affordability means. With respect to the deductible issue, I think they do have a good point. If I'm understanding it correctly, they're concerned that looking only at data on premiums is going to misrepresent people's actual experience. And there's certainly a connection between a plan's premium and the plan's cost sharing requirements. So even with a plan that has a low or a 0 net premium, someone might not be able to afford to access the benefits that the plan offers because of the cost sharing, with the deductible being kind of the biggest barrier. But I don't know how to address the issue with stacked deductibles, except by not looking at those plans, which again is like over 50% of the plans, is what I understand. So I guess that is an option potentially, is to put back in the deductible issue, but only look at plans with an aggregate deductible. I don't know how to go forward on that, but happy to hear your thoughts and any thoughts the HCA might have. And with that, I will try to answer any questions you have.
Thank you. I'll just open it up to the other board members.
I don't have any questions. I did want to think about the deductible issue a little more. I'm fine with, I think it makes sense to take an incremental approach and try to get the data, make sure it's going to work before going further, because I think we've learned a lot already in your process, Mike, in terms of how to do this well. On the deductible issue, I guess my question, which is not related to use of affordability in rate review, is why wouldn't we look at, and maybe it's not in the statute and that's the answer, at the affordability issue in the plan approval process? Because the where I get a little circular in the rate review process is we've separately approved deductibles. To your earlier point, that process is largely driven by the ACA metal level requirements, which we don't control. And so then, like it just seems, it seems strange to then import all, like we've made a decision, but then we're importing a different analysis not related to that decision into the premium review. So, so I've sort of struggled with the idea, like I think to the HCA's point, having an understanding of the impact in general is helpful to include the deductibles. I'm just struggling to see its applicability in the premium process specifically in this way. So I'm still thinking about that, but I just wanted to kind of put it out there in case you had thoughts, or certainly, you know, if the HCA has comments, they could address that as well. So that's really the comment slash mulling that I wanted to put out there for folks to contribute to if they so choose.
Yeah, I don't have a good answer. I, you know, I think it's fair to look at it certainly in the plan design review, but as you said, there's not a lot of wiggle room there. There's not a lot of ability to change things drastically. So
Yeah, and I think, you know, I think we all recognize that certainly bronze plans can be unaffordable for many people at many income levels, particularly in the individual market where there may not be an employer contribution to fill some or all of that deductible gap, which is a fairly common employer plan contribution. And I think that's been a challenge for the state for a long time. When we first were looking at the first version of the exchange legislation, basically prohibited bronze plans, but then the feds were like, nope, you can't do that, Vermont. So that legislation had to be changed to allow for them. So I don't know, it's like it's a bit of a struggle recognizing how challenging those plans are, but then trying to figure out how, like, what can we actually do about it?
Mike, I don't have much other than like the context of how this can be used is, to me, multiple. One, we have an annual report to the legislature. This information could be used as part of our reporting on how the state is doing in connection with various components of the Green Mountain Care Board's mission, an important one being affordability. Another use could be in the plan approval or rate review process. Another could be in connection with hospital budgets and considering whether those hospital budget requests are impacting affordability in a negative way. And then the last is just our evaluation, independent evaluation reporting on the system, kind of writ large, which has been something the board's been working pretty hard on the last several years. In terms of like, what do you do when there's an unaffordable rate? I think it's a good question. Although my answer to it would be, it's better to know you're approving an unaffordable rate than to not know and approve an affordable rate. And there's all kinds of various competing things in these processes, as we well know. So solvency, we have measures of solvency. We get letter reports on where solvency is, and we consider that. And so we should also consider the other factors as best we can in the most informed manner that we can. So I see this as being something we can use in a number of different things that the board is considering. And I think it is really important that we understand how we measure and think about a key core component of the Green Mountain Care Board's mission and what we've been trying to do as a state for a long time. And I wanted to quickly, actually, you reminded me that Jeff Batista did a lot of this work, and he is no longer with us, but I wanted to acknowledge his really good work on this and thank him for doing it because I appreciated it quite a bit. So thank you.
I think the only thing I want to add on the topic, and I appreciate Owen's delineation of several uses of this information is to support the idea that if that an incremental approach to this is better than not doing it. So I think taking an incremental approach and trying to revise and learn from what we learn each year to make sure we understand the impact of this information, but also I believe that using it as what Owen described as another piece of information and trying to evaluate the competing interests of rates is really appropriate. Because there are certainly rates that would not meet our affordability standard that are in the market. But yet those are important products for there to be in the market. So if we did approve them, we could potentially eliminate them. So these are complex, it's a complex balancing act. So anyways, I guess my summary of that is, you asked if, should we do this incrementally? And I think the answer to that is yes, we should do this incrementally and do what we can do and continue to move forward, understanding the limitations of the analysis. And if that means not having deductibles in this year, that we understand that limitation, but not give up on it.
Yeah, to be clear, I don't see this necessarily as the end of this work. If the board wanted to go this route with the revised guidance and simply telling the carriers what information they're going to have to provide on this issue, we could work to improve it. We could work to change it to a standard that, this is the rates that we will consider affordable or not. It may evolve and should evolve probably from here.
It seems as though we should take public comment on this. And I wanted to thank I guess the term is stakeholders, for being involved and spending your time to help educate us on the challenges and to make this as balanced as we can. So if there's any public comment, just raise your hand. Ham Davis, hey, how are you?
Thank you, sir. Can you hear me?
Yes, sir.
Thank you. This is obviously a hugely complicated thing, and I sympathize with the board that because because of the construction of the exchange and the metal levels and so forth, you really don't have a choice but to cope with them. But I just think that there really just isn't any. You really just don't have any chance to come out to square this circle. Is just plain too hard to do. One of the things I think is not true is that this is a new problem. The question of affordability is not something that's a cutting edge now. It's gone all the way back into the 1970s with the original driver of the regional medical program, which led to the Dartmouth Health Atlas and so forth. What I would suggest is that you just do the best you can, but basically it seems to me, what seems obvious to me is that the best way to solve the affordability problems is to bypass it by getting at the underlying cost, okay, which I think is the major mission of the Green Mountain Care Board. And I think that the way to do that is to bypass the whole question of rates. It seems to me that the rates completely ignore the question of medical practice patterns. You can have the cost of a procedure like an appendectomy or something like that can be high or low, or an appendectomy. Of course, all appendectomies pretty much are necessary. but all sorts of procedures are not necessary. Some medical people perform them at rates that are as high as 2 to 1. And so what seems to me to be the smarter thing to do would be to go to the question of looking at, instead of looking at rates, looking at costs. Costs are the rates times the volume. And if you were to do that, and you look at what we have on data in the house right now today, is that you can see that the costs within the overall system in Vermont are twice as high in some places as they are in others. And you have this enormous amount of data, and this battle has been actually fought out not only in Vermont, but there's been fought out nationally between the Weinberg approach, the small area variations approach that was born in Vermont, and and something called, I think it has a buzzword, it's HHS or something like that, which was developed by a health policy expert at UMass Worcester called Arlene Ash. And they've gone back and forth, and the feds have not done well on this. The feds are avoiding the problem that you're avoiding basically for the same reason, because it's so politically explosive. But in any event, good luck. But I just think that what would be much smarter, I mean, it would just bypass the problem. Because you have the ability now to take the basic cost of care in Vermont down by as much as a third. That machinery is in place. It's been set up by the OneCare Vermont. Nobody uses it, and the feds don't use it either, even though they're the ones that designed it into the Accountable Care Act. Anyway, thank you, sir.
No, I think those are really good points. It's always dangerous to make a quip, but if we're trying to avoid politically explosive, we're doing a very poor job of it. In terms of your point about getting at the underlying costs, I think it's exactly what we're doing. I think this is part of the information we need to inform ourselves and everybody in the state as to the imperativeness of getting at the costs. So if you look at our efforts to get at the costs, you can start with how we revamped the hospital budgets to really be able to do a better job of comparing cost growth and utilization and productivity and all of that. And I think that effort was pretty, it was a good first step this last year. We were able to drive down some of the costs in doing so. Second, I would point to the 167 work that Member Holmes and Lunge really promoted to get passed and worked with the legislature and the healthcare advocate and stakeholders to do, and the legislature's support and the governor's support to look at hospital transformation. That work we've talked about quite a bit, but a big component of that work is trying to look at the underlying costs of the hospital system and to make sure we have the efficiencies we need. So I'd cite first the improved budget process that's been in place for a couple years we've been working on, the transformation work, and then 3, the reform work. The reform work that we're trying to undertake now and evaluating is whether or not there are opportunities to eliminate some of the avoidable utilization or to move it to more productive places, more efficient places, more appropriate places of care. Certainly the state made a big effort and a bold effort with the all-payer model to do exactly that as well. That was the goal. I think there's many reasons we haven't achieved it as well as we wanted, but we've made some progress, and obviously we're all committed to getting at these costs. We look at them every day, and I think it's a really important point. Mr. Davis, I completely agree. Just measuring affordability and then cutting an insurance company rate doesn't solve the problem. It's the costs. So that's what this is to inform us to do, and we are doing. But thank you for your comment. I think it's really apropos and appropriate. Mr. Schultheis?
Thank you, Chair Foster. So I'm going to comment, and then a little later, Mr. Fisher is also going to comment, I think. So at the outset, I just want to name 2 things. First, I'm rather passionate about measuring affordability. And second, I'm not sure that the HCA's comments on the methodology used by the original guidance have been accurately represented to the board today. Although I do want to note that that's perhaps due to how this whole process has unfolded. Either way, I hope that these two things don't cause me to speak about the revised guidance in a way that distracts from my general message. But I want to acknowledge that that's a real possibility. So we appreciate that the board is considering explicitly measuring the lack of health insurance affordability that too many Vermonters struggle with. No household should be deciding between paying premiums, seeing a doctor, or paying for things like food and heat. Also, the HCA, like the board, welcomes the opportunity to collaboratively solve the challenge of measuring affordability. If there is one thing that I've learned over the last 15 years, it is that affordability and access are profoundly complicated things to measure. Despite that, I firmly believe that affordability is something that we can accurately measure if we work together. I also want to note that the board's continued efforts to create a system that speaks truth to the challenges Vermonters face is, to say the least, laudable. On a high level, the HCA's position on the revised guidance is that it is mistaken and that it should not be adopted. The revised guidance unintentionally silences the realities Vermonters face and is a substantial shift from the affordability guidance that we originally commented on. Our original comment is not applicable to the revised guidance that was released this Monday. Our position at a high level on the revised guidance is that it is worse than no guidance at all. As we've asserted over the last 7 years by presenting affordability calculations, and as we have done in our 2018 QHP affordability and 2022 Vermont Voices policy papers, speaking truth to the health insurance affordability crisis Vermonters face is critical, and those voices need to be better incorporated into the rate setting process. Incorporating the voices of Vermonters into the often hyper-technical rate setting process is necessary if we want to ground policy measures in the lived experience of Vermonters. The board has made substantial progress on making this hope of mine a reality. Unfortunately, the revised guidance will unintentionally undo much of this progress. So it's generally accepted that health insurance affordability should be assessed by both premium and deductible costs. And when I say generally accepted, one of the parties that accepts this is the very entity that provided the board assistance with this, namely the Commonwealth Fund. The affordability guidance has moved from looking at both premium and deductible affordability to now only looking at premium affordability. This change is misguided. Vermonters do not experience premium costs in a vacuum. Rather, Vermonters must be able to pay for insurance, that's premium affordability, and they must be able to use that insurance, that's deductible affordability. That a premium is affordable is irrelevant if the deductible a Vermonter faces before their insurance kicks in is $6,000. For me, guidance on any topic must produce results that make sense when it is applied. Because I wanted to understand the results of the revised guidance would produce, I ran a few scenarios. To my surprise, only looking at premium affordability yielded some absurd results, not in theory, but in application. Despite my natural inclination, I'm not going to bog us down in numbers. My colleagues and my partner told me in no uncertain terms that I should not do that. I am, however, still going to get into the numbers a bit because I'm rather stubborn and I do love scenarios. Under the revised guidance, a plan's premium is unaffordable if a given household must spend more than 8.39% of household income on it. Due to the federal premium subsidies, for the benchmark silver plan in 2024, only households whose income is above roughly 394% of the federal poverty limit will spend more than 8.39% of household income on premium. In other words, the premium is unaffordable if you make more than 394% FPL, but health insurance is affordable if you make less money than that. So what is 394% of FPL in 2024? What is the amount of money that you have to make more than for premiums to be unaffordable? Well, that's roughly $59,000 for an individual, $81,000 for a household of two, and $123,000 for a household of four. So what we're saying with the revised guidance is health insurance is unaffordable if you make more than those numbers, but it's affordable if you make less. Looking at that application, we see that the revised guidance denies the reality that low and middle income Vermonters struggle to pay for health insurance, and it instead suggests that it is the wealthy who struggle with health insurance premiums. But wait, why are you now talking about premium affordability when we listed so many technical issues with looking at premium and deductible affordability? That's not fair. Well, I can only speak to the intent of our comments on the original guidance. Our intent was to further the development of an affordability standard that was as accurate as possible. The calculation of premium assistance and cost sharing is a thing which cannot be mostly correct. It's a mechanical calculation that is either correct or incorrect. The method proposed by the original guidance was incorrect, but correcting those methodological errors is not insurmountable. The board's potential reaction to our comments, however, unlike subsidy calculations, exists along a spectrum. The decision between looking at combined premium and deductible affordability is not all or nothing. It's not combined premium and deductible affordability or just premium affordability. The board could have adopted a variety of possible limits on deductible exposure as a percentage of income instead. For instance, the board could use the actual Commonwealth standard of 5% of income if you're less than 200% of FPL and 10% if you're over, as opposed to the 5% it used for all households in the original guidance. Such a tack would show more variation in affordability across income and household compositions, and it would align with the reality of Vermonters' experiences, and it would accord with the standard employed by the Vermont Household Health Insurance Survey and the HCA, to name just a few organizations. Again, our intent in pointing out technical issues with the original guidance was to work collaboratively towards creating a better affordability metric, not to scrap looking at premium and deductible affordability together. Before I conclude, I want to address two issues raised by other commenters on the original guidance. First, it strains credulity that the original guidance would function as a hard rate cap, that somehow the board would ignore years of precedent and suddenly stop balancing the rate review factors. Second, commenters argued that deductible affordability should not be looked at because health insurance carriers have no control over planned deductibles, as deductibles are set by a mix of board decision and federal law. But carriers have essentially no control over the premiums that Vermonters pay either. Those premiums are set by federal PTC and state premium assistance regulations. Are we then to believe that consumer affordability should be a null set because we cannot look at things not in a carrier's complete control, i.e. neither premiums nor deductibles, this line of thinking logically leads to the words affordability being meaningless, and the board functionally just looking at solvency and actuarial reasonableness. This would result in two things. First, and most importantly, it would disregard the lived experience of Vermonters, thus unintentionally giving greater weight to the opinions of actuaries and finance professionals. Second, it would mean that the board reads applicable statute such that affordability is meaningless, something which the board has rejected and which is against the rules of statutory interpretation. To summarize, our office does not support only looking at premium affordability. We believe that the original guidance could have been correctly implemented, and we would welcome the opportunity to work with the board to make this happen. We do not support the revised guidance. Given timing issues, it is perhaps not reasonable or fair to adopt affordability guidance for payment year 2025. It seems possible, though, to do it for payment year 2026. Getting it as right as possible the first time is worth the wait. To be 100% clear, implementing the revised guidance would be worse than having no guidance at all. The HCA strongly recommends that the board reconsider the revised affordability guidance. Thank you.
Thank you very much, Mr. Schultheis. And I really appreciate your comments. If you could, if you have it available and you're willing, would you, if you have it written, or even just notes, I'd love to receive that comment and with the scenarios you outlined, just so I can look at it a little bit more. That would be better.
Absolutely, Chair Foster.
Great. And I think these comments that I'm anticipating getting are reflective of how important this is and how difficult it is. And we're not going to get it right the first time. We're going to engage with people and keep working until we have it the best that we can. Not everyone will ever be happy with it, but this is our job, and hearing all sides of this discussion is really, really critical to us doing that as well as we can. It reminds me of this band. They were once asked, how did you get so successful? And they said, we were allowed to make mistakes and our audience kept showing up. And it sort of reminded me of this process, that it takes a lot of time to get it right. And we appreciate everyone engaging with us as we do. I'm going to go back to Mr. Davis, because I think he was trying to comment when I moved on. So Mr. Davis, go ahead. Ham, are you there?
No, I've got it. I was muted. Thank you, sir. I didn't really have another statement, but I would like to say something. I don't know whether it fits into the way you want to run things, but I've been here for a long time, and I have been and I have listened to the Vermont, the whole the healthcare advocate thing structure since it was invented by Paul Poirier way back in the early days when our reform project was just started. I would just like to say that the comments by the comments that you just heard, that you asked to be written out, okay? I hope that you, Mr. Chairman, will share them. That discussion that just took place, that series of comments that just took place, are, in my experience, and I've been here forever, is the single most clear and valuable exposition that I've ever heard from the healthcare advocate. That's all I wanted to say.
That's a high bar. Ms. Teachout?
Thank you for the opportunity to speak. I'm Sarah Teachout, representing Blue Cross and Blue Shield of Vermont. We very much appreciate the Green Mountain Care Board grappling in a systematic way with the issue of affordability. And I very, very much appreciate all the thought that the Healthcare Advocates Office has provided on this issue. While we don't agree with every one of their points, we certainly appreciate the depth with which they've gone into this issue. We oppose adopting this revised and what we think is very deeply flawed guidance for a number of reasons. I won't be as comprehensive, I'm sure, as Eric, but we think that adopting this in 1 to 2 weeks before the filing of our rates in 2025 is too short a timeline and too last minute to move into this. We also don't support this piecemeal approach. This let's do some of it now and more of it later. We'd really like to work on an entire plan together that includes not only the measurements, but also how the board intends to use the guidance. We think there's too many pieces of this still in development that need to be worked through. And so we do not want to, I guess I said it already, but we don't really appreciate the piecemeal approach. Lastly, most of this information, at least in the revised version, you already have, and I think is just asking for calculations of information that's already quite public. So for all those reasons, I really think that rather than all this back and forth with memos and a lot of like pretty labor intensive back and forth, we would appreciate getting together with all the parties who care, talk through some of these issues in the level of detail and depth that they require. So that would be our recommendation, to do that moving forward. We don't oppose talking about affordability. We understand how important this is to the process and to Vermonters, but we'd like to do it in a way that's comprehensive. So thank you for listening.
Welcome, and thank you for your comment. I have one observation to make. I asked VAHS and insurers to provide me information and thoughts on how to evaluate affordability when I first got to the care board. Voluntarily give me your thoughts. I have yet to receive that input that I'd asked for almost 2 years ago. So this effort was then in response to the fact that we didn't have much participation in that endeavor. And so we're endeavoring now, and to the suggestions and ideas that we all get together to discuss it, I think it's a really good idea, and we'll do that. This is an important issue, and we need everyone's voices, and we need to get it as best we can. So I appreciate the time that people spent and the offer to get together to do it, and we will do that. Mr. Carpenter.
Thanks, Owen. Eric pretty much stole what or talked about what I wanted to bring up, but I wanted to look at the affordability issue from a patient's perspective. And I thank the board for doing rate reviews. I'm not going to say whether this rate review is bad or whatever. I'll leave that to the ACA. I have the extreme pleasure of a colonoscopy coming up in 2 days. And before I went up there, I had to call the people doing it to find out how much the deductible would be. And if the deductible would be too much, I would have to cancel it, because you're looking at $500, $1,000, something like that. You never know what the prices are as a patient. I had gone in January. First of all, I'm on Medicare. I was on Medicaid. I got kicked off of Medicaid in the great Medicaid purge. My expenses went up by $4,000 a year because I had to buy one of those supplement programs, which carries a deductible, of course. And I had gone in for a stomach complaint in January, and I got hit with a $200 deductible. So hence the calling, hence trying to find out. This is the reality of patients in Vermont. You never know if you're going to get hit with it. You never know what that deductible is going to be. So I had to talk with the office for an hour or so to try to get them to switch things around so that Medicare would take care of it and I wouldn't be hit with a $1,000 deductible. The deductibles, as Eric pointed out, are a huge issue, and we know the history of them and why they were put into place, so I won't reiterate that. But that's the main problem the biggest problem for Vermonters trying to overcome this struggle with costs. And I almost canceled the procedure because the costs were going to be too high. But we figured out a way to do it where we could at least lower it to a point where maybe Medicare will pay for the whole thing. It was a switching of codes and stuff. And that's what goes on. So again, I thank the board for the rate review discussion. Thanks to Owen for leading it.
Thanks, Walter. And Mr. Fisher.
Thank you, board, and thank you, Mike Barber. I really appreciate the discussion leading into this about sort of the challenges of your work, and we appreciate the tone and that discussion. I thought it made sense for me to sort of follow up from Eric's comments, which were decidedly on the more technical side, with a little bit of a higher level discussion. What does affordability, what does consumer affordability mean to us over at the HCA on a high level? It is reducing the number of times where people are forced to make a budgetary choice over a healthcare choice. Something none of us think is right, and we know happens all the time, and flies in the face of so much of what we're all trying to get done. So I think of a few scenarios. You know, let's say I'm a modest income individual in the individual market, you know, just above the high CSR levels. And my provider says, you know, I really want you to see PT twice a week for 3 months. I want you to really dig in on PT. All right, $50 a pop in copays. Or if it's OT or speech pathology or other therapies, it's $90 a pop. And you can well imagine someone at modest income, you know, say $38,000 a year, saying, I just can't do that. It doesn't fit in my budget. Or let's say I'm, you know, part of a family and I have a employer-sponsored plan, again, modest income, yeah, with a $12,900 deductible, and I'm suffering from depression and anxiety. I function fine on some days, and some days, you know what, it's hard, and I really need some help. The challenge of paying for that deductible to get the help I need might be insurmountable. So what does it mean to me in either of those scenarios to have the board say, your plan is affordable? I think that's the main point I want to make. I'm afraid that saying that that person has an affordable plan projects exactly the wrong thing. You know, here in America, we blame ourselves and we blame each other for poverty. We don't recognize poverty as a structural problem. We tend to think of it as a deficiency, that something that we did wrong that led to us not being able to pay our bills. So, you know, the final point is that I'll just say it again. I'm really fearful of what it means to say these plans are affordable. And what is it, you know, how does the regular Vermonter who's struggling with one of the scenarios or hundreds of other ones when they hear that? I think I'll stop there. Appreciate the conversation and look forward to more of it.
Thank you. Dr. Merman?
Can I just, Mike, ask you a follow-up question to that?
Yep.
You know, in general, just the richness of this conversation is great, and I think this is really helpful because we're really clearly wrestling with the complexity of this issue. Mr. Barber was talking about the challenges of trying to understand the deductible impact on affordability, and I think we all acknowledge that clearly that needs to be integrated. But I guess my question is, if we were to look at it this year without the deductible, sorry, Eric, just hypothetically for a second, okay? And think about evaluating plans as a clear unaffordability cut. So clearly there's lots of things that could push this into it to being unaffordable as well, but of the basic information we have, and then we find plans, maybe not ACA plans, that are clearly unaffordable. Would that be helpful information to have this year while we're working through the deductible component over the next year? Or do you think that would be potentially bad to know that somehow?
Well, I think my understanding of the way this will play out, the draft notice, the draft plan, is that quite the contrary. You'll see plans as affordable, plans that we're very concerned about, and so I don't see how it will put pressure on you. And
well, so I'm wondering if in the interim, if we could flip the affordability to, like, if we could change the way our interim guidance goes into defining a clear unaffordability cut. Now, it's not totally inclusive, but if there's plans that are clearly unaffordable just off of premium, not even considering deductible, if that wouldn't be a helpful piece of information to have at least publicly defined this year while we're adding the deductible component, which I think, I mean, I thought was important before Eric spoke, but now I'm, redoubled that clearly understanding the impact of deductibles is of incredible importance, especially in bronze plans, but even in silver plans and fully subsidized plans.
Yeah,
hypothetical.
Remember, Dave, it's hard for me to not fill in the other side, half of the equation, saying, these plans are unaffordable. How do you say these plans are unaffordable without recognizing the other ones as affordable? It's just hard for me to think that through.
Yeah. Thanks. Just a thought. Yeah. Thank you.
Great. Any other public comment? Okay, this will be continued. Why don't we take a 5-minute or a 6-minute break? We'll come back at 2:20 to go to our global budget discussions. Thank you. I'll see you in a couple minutes.
Good afternoon, Elena. While waiting, do you want me to share my screen?
Yeah, I think that'll be best. And I think you can dive right in. I won't do my intro. I can circle back if we need to at the end.
Do you see the slides?
You do.
I mean, you can do, I can jump between
No, I
slides.
think,
Yeah.
yeah,
No?
I think I'll go back to that when, I know you have a hard stop at 3, so we want to make sure. Yeah.
Sounds good.
Okay, we can resume our hearing. Ms. Julia Garavich from Mathematica is here, and Ms. Barabee. I believe we'll turn it over directly to Ms. Garavich to continue our presentation on global budgets.
Thank you, Mr. Chairman. So we are going through the slide deck that we shared on Monday, but as we get feedback from you and the questions, we are updating it as well. So this is an updated version of the document, and I will highlight a few things from the Monday, and hopefully that will also refresh where we left on the Monday discussions. Just quickly, as a reminder, we are focused on Medicare methods in the global budget payment development. DIVA has been working on the Medicaid methods, and we deprioritize commercial budget methods to get ready for the ahead timelines to submit the Vermont version of the global payment methods. We do expect that there will be excluded revenues no matter what decisions were made. So the global budget revenues will be calculated based on the methods approved if Vermont decides to join the AHEAD program. And then the GMCB's hospital budget review process will continue to manage the total NPR as it's currently doing. I'm going to jump some slides now. So So the way that the budgets are established is we are starting with the historical revenue, and we did discuss ideas around increasing the funding to support delivery reform. So those are the baseline incentives. And then on an annual basis, there are certain adjustments. The first group is what we call medical inflation and the policy adjustments aligned with CMS. The next is utilization adjustments. These includes membership and service line changes. And then the last group of adjustments include performance. On Monday, we ventured into utilization. So I'm going to start from the utilization, but I do want to also indicate a few updates based on your questions from Monday. Chairman Foster, you had asked about the dollar value of the difference between Vermont average Medicare per beneficiary spend on Medicare versus the national. Our estimate is about $132 million total dollars. If Vermont spending was at national level, the Vermont spending should have gone up by $132 million. The next question was around
annually.
Annually, yes. Yeah, 1 year, based on the 2021. There was a question around the private insurance. So when we talk about commercial insurance in the AHEAD terminology, that includes Medicare Advantage. But when we are looking at private insurance in this table, it's the private funding. So those are the employee-sponsored and individual plans. So this table shows only the private health insurance spending, which kind of aligns with the way that the GMCB has been thinking about the commercial insurance. So that's the clarification. And then the other one was around hospital care from Dr. Merman. Hospital care in this table includes hospital services provided by hospitals. That does include physicians employed by the hospitals, as well as any other services the hospitals provide. So that kind of aligns with the way that we were kind of calculating the adaptive numbers for hospital revenue. So hospital NPR.
So our hospital-based primary care is in that hospital care dollar amount, and our outpatient hospital services are in that dollar amount.
That's correct. All right. So
And
hopefully
can I
that.
just- that the slide before that that you highlighted, I clicked through that link a couple days ago on the bottom there, and it was interesting because the 2020 commercial spending is much closer to the US average, but which is the most recent year through KFF. But if you go back the last 5 years, it was much more in the sort of 20 to 25% above national average. So I think 2020 with COVID is sort of a little bit of an unusual year for our commercial spending in Vermont, just a FYI.
Great, thank you. Right, we'll dive into more on the commercial as we, I think, work on the commercial methods, but this is a good understanding to begin with for how we can see the Medicare vis-a-vis the other payers. So now we are going to go to the annual updates. We are starting with inflation. The inflation graph is also updated, and as I added the 2023, I also updated the forecasts. So they haven't changed significantly, but the CMS is projecting the medical inflation to come down from the 2022 spike from 5.9% down to about 3%. So those are the current projections. They are updated on a quarterly basis, and the methodology is whatever the most recent update. We'll take that number as an inflationary adjustment for global payments. On the utilization, we have talked about beneficiary changes and service line changes. The beneficiary changes are kind of obvious in a way. If Medicare fee-for-service enrollment declines, the global payment will be declined, adjusted for demographic factors. Here, we also updated the enrollment trend, and I'm going to make this bigger. Would that work? And after this, I will make it really big. So as you know, the members have different risk profiles. So the beneficiary adjustment will include adjustment for age, gender, and ESRD. Our method is different than CMS on the adjustments and the way they calculate. And in this table, we added 2024. Originally, we had VCures, and thank you for the note that VCures doesn't include all the MA plans. So we went back to CMS original data tables and pulled these right out of CMS tables. And what you see here is a little bit similar story, but the numbers changed slightly. In 2023, we have a decline about 2.8% in traditional Medicare membership. And in 2024, as of January, we do see that the decline is at 1.2%. So we do see a slowing in the declines, and the growth in the Medicare Advantage also kind of tapered off, looks like, in 2024. And the market penetration is also updated. 32% of all Medicare beneficiaries are currently in managed care enrollment plans. So the methodology is going to take the change, so minus 1.2%, and calculate that on a age and gender ESRD adjusted basis. And we will allocate that to hospital global payments based on their draw from different hospital service areas. So we will take into account the migration from different areas. So this number is going to be different for each hospital depending on where their patients are coming from. Any questions about the demographic adjustment? This is where we left on Monday. So now I think I could even make this bigger. So
Shule, can I pause you right here before we go into this? So as we go, I want to try and see what an example would look like. So would it be possible to run through an example of how the baseline would work for a hypothetical hospital? So if you go back, I think it's slide 31-ish, you had the various baseline adjustments. Right. Okay. So
Baseline,
I'm
sorry,
gonna
this is annual one, sorry, this, let me. My
yeah.
updates, baseline, this one? This is our
Yes.
starting point. Yep.
Right. Okay. So I'm going to try and say it, and you can correct me when I'm done. But first, we start with the baseline number, either the 3-year average or the highest year of those three. So we'll call it $100 million. From that $100 million, we're then going to add 1% for the transformation incentive, right? So $101 million. And then we're going to negotiate or see whether or not there's additional delivery reform money. We'll just hypothetically say it's another 1%. So now we're at 102%, sorry, $102 million. And that is now the baseline budget for that particular hospital, right?
No, we would then add well, that's the baseline starting number. It's not the budget yet. Correct.
Right, okay. Then, all right, then you had another slide for that. Go to that one.
Now we are here. So now we are going to add inflationary adjustment.
Right, okay. So then we go through each of these and that adjust it more. We'll call this another 5%, or maybe we'll go 8%. So we're at 110 million now. That will be the budget for the first year for the hospital at issue. After that, we have some level of savings from historical performance in the state. The point you were just talking about how Vermont compared to national. Now that amount of money would go on top of the 110 million from these baseline calculations. Is that right?
So 110 million, sorry, let me understand what you're asking. So we have 110 million global budget payment calculated. And we have 138 million, that's the difference between Vermont and national average, right? So
right.
We haven't discussed the state savings requirements, right? So when we negotiate state savings requirement for Medicare, you would have a number for performance year 1 for the overall number. Let's say that number needs to be 200 million, right? Because it includes hospital payment as well as other provider number. So if you negotiated a 200 million savings, then you have that delta between 110 plus all other provider payments, whatever that delta that you negotiated is going to be state performance. So as we put the 110, there's going to be impact on that savings requirement, right? So you have to factor into whether that additional 10 million is going to be within the state overall target.
Okay, hang on. I apologize. I got a little lost. So the state has, we'll call it $200 million in savings, and we would like CMS to recognize our historical low cost status. So hypothetically, we negotiate and we get $200 million in savings.
Yep.
That $200 million in savings goes where? Does it get divided by the number of years? And so you get it each year, and then divide by the number of hospitals or the amount of Medicare money in the program? Does it go on top of the $110 million to come up with your total cost of care for that hospital? Or does it go macro for the entire state's total cost of care that's in the program?
So I think that's a great question, and probably we want to work through that in the next meeting, but at a higher level, you negotiate your savings, and that's hypothetical until you find a way to pay the providers from that savings. And currently in the methodology, in addition to that 10 million that we calculated, which is coming from 2% from social risk adjustment and other things, the only way for us right now is what we called Vermont Delivery Reform Funding. So whatever that additional funding that the state could negotiate could be the pool available for this baseline incentive.
And by that, you mean this delivery reform funding could be from our historical savings?
Correct.
So I'm sorry to get advanced or behind. I don't know where I am. I'm just trying to understand the mechanics. If we have the $200 million in savings, how do we go from getting recognized and negotiating that to drawing it down?
Good question. So let me jump to the, as I mentioned, I'm good with visuals and numbers. So here is our current spending, 10,000 per beneficiary. And CMS is going to create the trend off of this, right? So you would be able to grow in the state savings one, let's say 5% growth on an annual basis. When the negotiation happens, you could ask to add that 100 million savings to your base. So instead of 10,000, your starting point is going to be, let's say 15,000. And the 5% growth rate will be applied to 15,000. But that's not actual money until you say you have this 130 and figure out how you can add it to the global payment or any other provider, depending on the negotiation. That will be the actual savings that you could recuperate to the providers, bring back to the state. Otherwise, even if you negotiate and you start with 15,000, you are guaranteeing that you can grow more than 5% and you won't trip that statewide benchmark. Exactly. Right. So one is you add it to your baseline, or instead of 10 million growth, we could have the global budgets grow by 15 or 20 million. You could add it for the future, or you could add it to the baseline.
Okay. So 15,000 because we've got the historical recognition, and 10,000 is what we're actually going to spend. And we have we're just making up numbers here. So we have a $5,000 delta per Medicare beneficiary.
Yep.
And that $5,000 per beneficiary is realized by a hospital. How? What are the next steps for that money to be realized?
So you could increase the global payments by giving them additional funding with certain policy options. So that's the first one, baseline incentive, right? So of that $5,000 difference, you could say, I will have a pool of $2,000, and that will be distributed to the hospitals to fund their transformation plans. And there could be a lot of decisions around it. The other one is that you could also think about those annual adjustments and have additional adjustments. For example, social risk adjustment is up to 2%. If you have a room, you could grow that, you could give them 3% and rather than 2%. So that's another way to provide additional funding from the historical to the budget years.
Understood. So, and then those adjustments, so we can either put it in the baseline through those first baseline things you had or whatever's negotiated, or in the annual adjustments. And then the maximum amount those could be, so right now they're 2% or 1% or 3%, could be up to the ceiling of that total cost of care delta, 15 to 10. We have $5,000 per beneficiary that we could distribute amongst those various annual adjustments.
Correct. The only thing is you also have to factor into what your future projections look like. If you distribute all the maximum amounts, that you have to maintain the growth rates, right? That 5% growth rate that you are going to be subject to. You need to make sure that you can meet those requirements in the future. Instead, you could leave a little bit buffer to manage that risk going forward.
And is there clarity yet as to what happens if you go over? So let's say we're at 10,000 in actual spend, 15,000 in targeted spend. We then distribute the full MOTI, $5,000 per beneficiary to a particular hospital through these adjustments. But the next year, lo and behold, they end up going to 17,000. So they're 2,000 over. What happens in that scenario, to the best of our knowledge at this point?
Yeah, I need to go back and check the specifics. At minimum, you're going to get corrective action plan. And there might be other repercussions like paying back the advance payments that they give to primary care or something like that. I can go back and pull that information from NOFA.
Okay. This was helpful to me.
Okay,
Yeah.
great. I'm actually glad you're asking. So it also makes me understand what your main concerns or where you want to focus on.
No concerns, just trying to understand as best I can. So as we go through this, so thank you. And sorry to interrupt.
And Shule, can the percentages that we're proposing in this methods paper, are those locked in? So for instance, if we do end up having the opportunity to do a 4% SVI adjustment instead of a 2% SVI adjustment, can we change that at a later time, or is once this method is locked, we're locked into it?
Another good question. We need clarifications in all of it, but in general, all these methodologies in the past, you have annual updates, and there could be languages there that the state reserves the right to change the methodology in the future. So I believe that would be accepted, and other models have been making changes on an annual basis, at least until they get to a place where they feel, okay, no more changes are needed. All right. Any higher, should I continue, Chairman Foster?
Please do.
All right. Okay. All right. So we gave inflationary adjustment. We calculated the membership changes. And now the issue is we do not want to keep the budget fixed. We need to allow some modifications based on their service line offerings. Healthcare is changing, and hospitals are expected actually to think about their service offerings, and hopefully Act 167 community engagement is going to provide us with action plans. But the question is, what happens if the care plans change? The first one is around market shift. If the patients start going to one hospital to the other, what kind of adjustments we would like to have on this global budget. So this is more looking retrospectively in that first year and seeing, okay, the patients were going to UVM, but now they are choosing to go to Rutland, and I'm just making up these numbers to make it more concrete. What kind of adjustments we would need to make if both of hospitals are in the global payment, or one of them. Right, so they don't have to be both. So one of them, if one of them is there, what do we do? The second is planned service lines. So this idea is that hospitals will make changes inevitably, that they would submit those changes to the state, and there will be prospective adjustment for these changes. Hospital may come and say, we are expanding our surgery, GI surgery, and I'm planning to hire a new doctor, and this is the expected volume growth for these services. Prospectively, there will be additional revenue for those changes approved by, I'm going to say state, I'm just using state as a general term, not GMCB versus AHS, just the state. So there will be some approval process for budget adjustment, and that revenue will be added to the global payment prospectively. Conversely, hospital will come and tell you that I no longer can do or need to do certain procedures at my hospital, and that would reduce their global payment. The question in this one is, as you are thinking about how much money will be taken or given to global payment, how do we balance the incentives and create the focus on population health service lines? In the CMS methodology, they provide 2-year fee-for-service amounts for the new services. And then when there is a reduction or elimination of a service, hospitals can retain up to 50% of their revenue in their global payment. Why? Because we want to incentivize hospitals to make those decisions based on population health and priorities the state sets forward, rather than concerns around losing the revenue at 100%. 50% comes from variable cost factor, meaning that any additional patient creates additional costs from staffing, supplies, and in this case, CMS uses 50% as a cut point. The last one is, we talked last time, well, we cannot really measure shifts to other providers, or that our service line adjustment may not capture everything. They may miss, things happen during the year. The last one is the unplanned volume change. This you could see as a control mechanism, that if the volumes are changing plus and minus 5%, CMS envisions to have adjustments for anything above that 5%. And again, they're applying that 50% thresholds to make those adjustments. And there are special considerations for critical access hospitals because their fixed revenue is much higher than PPS. This is quite a lot. And
can I ask a couple questions on this slide?
Of
So
course.
the two areas that I have a lot of interest in are in the service line adjustment, the new services, and the contraction of services, and sort of how that creates incentives or disincentives to change. Well, the contraction is complicated, and the new service is complicated. So in the new services, can I just play out a scenario? Of my understanding is, so the hospital would plan that they want to expand a service. Say they want to, there's more demand for colonoscopies in their region. They want to hire a couple new gastroenterologists. So that service then would need to be approved at that level by CMS and some state entity.
For a budget adjustment, they could do whatever they want, right? So they could still do, if they want a budget adjustment, it needs to be approved by the CMS and the state.
So they could hire people, but they wouldn't get any more money unless they went through CMS and the state to approve the hiring of, say, those 2 gastroenterologists.
Correct. The budget adjustment will be approved, correct. Or they could wait, and if they think they are getting it from another hospital, right? So there is that retrospective adjustment. If they hire GI and they are bringing the services to a local hospital, and the assumption is it's going to not go to tertiary, it's going to come to local. So they could also get market shift adjustment in that scenario. But at the front, if you're hiring 2 GIs, you have a fixed budget. Hospital could request additional funding, and that needs to be approved to add it to the global payment.
And then under the Medicare methodology, which we haven't, I don't think, put in the state methodology, they would then be fee for service for 2 years once approved.
Correct.
Okay. So just, okay. And then on the contraction elimination, say, for instance, a hospital said, okay, well, we're going to eliminate our 2 gastroenterologists, and say it's a critical access hospital, and they don't get a downward adjustment, but now they can't keep, say, a patient in their inpatient service who has a GI complaint, and that has to be transferred to another hospital. But there's, I guess, is there anything to stop from to disincentivize elimination of services at a hospital then?
Yes, they will lose on the market shift, right? At the end, if you look and those GI patients end up in another hospital and that hospital has 0, they are going to use it at the end of the year. So that's one disincentive. The other one, if we adopt the unplanned volume shift one, the third one, if their volumes are lower than 5%, they will be losing the revenue again, right? So those are the two disincentives to close the service lines.
But in the unplanned volume adjustment, that's a total volume, right? That's not a per service line volume we talked about before, right? That's all their volume. So that's a huge shift potentially.
Right.
And then the market adjustment is based upon what then? Is it based upon a specific service line? Okay.
That's correct. And you could, I mean, this is CMS methodology, and we haven't really formulated the Vermont version of it. And this is the time, if you think we should do this at the service line level, I believe no matter what adjustments are, there needs to be a monitoring at the service line level, right? So you do want to understand what's happening.
How's service line defined? Is it a group of codes, a group of ICD-10 codes, or is it?
Yes, mainly. There are clinical specialties. So the ICD-9 codes and the DRG codes are mapped into clinical specialties for inpatient and outpatient services.
At some point, could you send me some clarification of those definitions? Thanks.
Yep.
Thanks.
That's
Sorry
another
derailing.
detail that we need to decide how to do it, but there are some standards that we could share with you.
Could I ask a clarification too, in Dave's scenario where the GIs are contracted or eliminated? If that is prospectively done, that still in order to keep the 100% payment, that still requires approval. So that is another potential, I won't call it a disincentive, but there is an approval process there. So it's not like the cut happens and the 100% is guaranteed if it's not approved. Am I getting that right?
Right. So if you do the service line assessment at the end of the year at the service line, hospital has a choice. If they report in advance, they may keep 50% of that payment, right? Or 100% if they are caught. If they don't come and get approval and it happens at the end of the year, they lose 100%, right? Or 50% if they are caught. So there's an advantage to come and get approval for closures, so they retain some revenue versus losing it at the end once you look at it and see that they no longer provide that service.
So when they do their budget, they would come to the care board and say, okay, we want to eliminate a gastroenterologist from our hospital, and maybe their GI doc left and they only have one GI doc, and so they can't replace them, so they want to eliminate that. And if we say, yes, you can eliminate that position and not hire another GI doc, then they get to keep 100% of the revenue that was attributed to that doc. But then how do we make the determination whether or not to allow them to add or eliminate positions?
The CMS envisions the state health plan, and the health equity plan would create parameters. There is also in other places, you could develop a list of access related service lines where this becomes a little bit more automatic in the rural communities. And I can share that list with you as well. And I think you have done your own assessments in the past, I believe, on the sustainability work, and the community engagement work from Act 167, I'm hoping is going to create additional lists or considerations for how you can make that assessment. It has to tie to access, population health, I think. So you have to create, there needs to be a criteria to assess those approvals.
So we would need better measures of access than we currently have to be able to implement this. Probably number one. I'm also just thinking about, I'm actually trying to think about the logistics of this approval process, and thinking about its close cousin, which is CON, and what we do in evaluating need in CON, and the time it takes to do that, and the data that we use to evaluate that, and realizing too that CMS would have to approve it. I'm just wondering, how quickly service line adjustments would be approved. The data that would be needed would be need volume by service line, fixed cost, variable cost by service line, access by service line by HSA. I'm trying to understand actually on the ground how this would be implemented. So maybe we just, there's more time, you know, more food for thought that we have to think about, but logistically how this would actually happen.
So I can give you the experience from other states. It takes a while to get it organized, right? The first year it takes a while, but once the decisions are made, I believe in 2 months, those things are approved. The other piece is for the new services, you are not getting additional risk, right? So all they are getting is a fee for service equivalent. So you are not paying them additional. So the risk for new services is minimized compared to fee for service. For those that are closed is more challenging because some hospitals may need to rearrange and reconfigure their services. And at what point you leave some revenue to enable that happening. At the same time, you know that if that service is closed, those services needs to be provided in another organization, right? It's double, we used to call it double pay. So if you keep it in the global budget without adjustment, patients are receiving another from the system side, you know, you have a total cost risk because you will be paying for those services at another hospital.
I guess that's also what I'm trying to figure out too, the total cost risk associated with, for example, critical access hospitals keeping 100% of the payments. So I'm trying to think about how this all works in terms of actually improving efficiency, ensuring that, you know, patients are getting, that we're incentivizing delivery system reform, while at the same time, this particular service line adjustment seems to be a little bit counter to that. If there's contraction or elimination, but retention of payment, I guess I'm still trying to figure out how that's all going to work.
Yeah, I mean, there are other considerations you could think about overall where they are vis-a-vis their volumes versus budget, right? When do they need additional revenue for new service lines? And in the closure case, it's the balance between ensuring access is there. So you do want to kind of track and adjust the global budget down. So if they close, what Dave was asking, what is the incentive? I just close the service and I keep the revenue. So that's where on patient perspective, you do want to make sure they are impacted. Hospitals are impacted by closures. But at the same time, given where you are with access and critical access hospitals, you need to find for them to deliver different care in different settings. And they, you know, that's all balancing. And I agree with you. There are a lot of considerations besides just what percent payment and how, as you're considering in which conditions you're going to make these adjustments for which hospitals.
Can you just explain, sorry, the market shift adjustment, paying 50% of average cost? Could you go over that again, what that looks like?
I am not, yeah, I put it in parentheses because the NOFO and the spec says average cost, but they do not define what they mean by average cost. I'm just going to assume CMS is thinking their payments as a cost, so they are going to pay 50% of what they normally pay on their fee for service revenue. So I put it in, the term they used is cost, but they never define what that cost is in their revenue. So to me, it's really what they would be paying on the claims. So it's a payment. But, you know, you may have different considerations. And I do not, from the administrative perspective, I think it will be challenging to have these 50% variable costs at the service line level. I think it might be less burdensome to have a number at the hospital level and not worry too much about the service line specific level, but maybe inpatient versus outpatient could be a different number, right? Inpatient fixed costs are higher, outpatient is not. So there might be some consideration for those, but doing it at the service line level is, I believe, impossible with the current accounting systems hospitals have. And, but that's
Okay, and this is
my
just the
experience.
CMS methodology at this point.
This is
There
CMS
hasn't been any
methodology.
proposed Vermont methodology as of yet for this.
Correct. We need your input, your feedback to develop that piece. Which we have.
Two little.
Yeah.
Sorry, I just want to finish on that slide. Two small questions. If the service line adjustment keeps 100% or 50%, you're saying we're supposed to capture this in the market shift adjustment. How do we know how much of that they're retaining is being actually captured by the market shift adjustment? And then how do we think about how much of it we want to be captured by market shift adjustment as opposed to maintain to invest elsewhere?
Maybe it's easier to think for me in terms of utilization counts versus payment adjustments. In the market shift adjustment, we track utilization, and that we expect that if one hospital is going down, the other one is going up. So that's an algorithm that will give you one hospital experience 100%, 100 cases less, another hospital picked up 50 of them, and that's the adjustment you make. You assume that only 50 patients went and got the service from another hospital.
Let me try this example. We'll go with Dr. Merman's example. There's 4 colonoscopists. Their practice brings in $100 grand. Or sorry, urologist, and $100,000. And then they all leave. It comes to the care board and to CMS to review and say yes or no. We say yes. So $100,000 is gone. But if it's a CAW, they keep $100,000. If it's UVM or Rutland or whoever, they keep $50,000. Right? So now we're having less service, but paying the same amount of money or 50% of the amount of money, which we don't want because they're going to go get it somewhere else. And you were saying to Dr. Merman, we would capture that subsequently in this market shift adjustment.
Yeah. So in the first case, you approved it, you are keeping the 50% because hospital has fixed costs. The idea is that you are financing the hospital's fixed costs because they are lost of that 100,000. They still have to have certain infrastructure to maintain their services. So that's the idea behind letting them keep 50% of that historical revenue.
Right. We want them to have the money for their fixed costs, but at the same time, we don't want to spend a whole lot of money to maintain the fixed costs and then pay for that service to be somewhere else, because now we're paying twice.
The paying twice is when they don't tell you, you don't approve this, they close their GIs, they did not get approval. In that case, you look at where patients are going and the budget is adjusted. So you could think about market shift adjustment and you could do it at 100% if you are trying to balance it. So there are a lot of decisions and they are interrelated. If they don't tell you and the patients go somewhere else, they close their service and you run the algorithm and it's another hospital, the budget could cut at 100%. CMS chose to do it at 50%.
All right, so let me try and finish my made up scenario. So $100,000 for that work, it goes away, we approve it. CAW keeps 100% of the payment. They keep 100 grand.
Yep.
Those patients now go to a different hospital. That different hospital or outpatient surgery now bills for it or needs a market shift adjustment if it's a global budget hospital.
Right.
And so we add money to their global budget. So we pay
Correct.
hospital 1 that lost the practice, we pay hospital 2 that added the practice.
Correct. But you pay those hospitals again based on what they are at 2-year fee for service, then it comes under, or you can also pay them at 50%. If at the end, if it is just a variable cost factor, the other hospital also needs only 50%, right? Because they already have their fixed costs covered under global payment. So we are changing the marginal changes. So those additional changes, the impact, financial impact, those additional changes.
Okay.
But at the
Unless
end,
they
you
didn't-
are paying,
Unless they didn't have the practice, in which case they need to add to their fixed cost to add the practice. Okay, and then just, so we're going to be paying more in that scenario. And then the hope is that by keeping that 100% of that $100,000 at the call or 50 at a PPS, they're going to then do a new service that is really advantageous for population health. We capture that where? How do we make sure they use that 100 grand in an advantageous way for the population?
hospitals are required to do the health equity plans. You could also require transformation plans. Other models have done that as well. So hospitals give you a strategic plan and tell you what their plans are. So if
So they keep the 100 grand and then they come and give us for each one of these things a plan that tells us what they did with the 100 grand.
You know, they in other models, we haven't just, in other models, hospitals are required to put a transformation plan as part of participation requirement. So this is the financial model. In addition to global payment, you would require hospital to give you a strategic plan under this model. Because just like you said, in the model, we are going to leave certain funding if they close services. So you may require them to give you a strategic plan, what they're going to do, how they're going to do it, and they can update it on an annual basis. And the service line adjustments would need to tie to these strategic plans and the population investments that they are planning to do. Obviously, there are temporary things that could happen. Doctor can retire and they would need to hire someone new. So those are the things that you also have to spell out in the methodology, how you're going to treat it.
Okay. And then this might not be the right, you might not be the right person for this question. So if you don't know, that makes sense to me. But this is a close cousin to certificate of need, which takes people and resources. I have no sense myself sitting here today how often these types of service line adjustments happen. How many of these would we have for 14 hospitals in a given year? And if you don't know, it's a totally off the wall question. So
we tried to look at the data and the data wasn't clean enough for us to understand what was going on. But I could give you from another rural state experience. Of the 18 hospitals, we have about 5 every year. And then with 2-year cycle, it kind of ranges from 3 to 6 in a given year. New applications are about 4 or 5.
3 to 6 service line adjustments amongst about 18 hospitals per year, and then 4 to 5 additional service lines. So you're looking at 10 or 11, 7 to 11 a year for 18 hospitals in your other example.
No, not that much. In a given year, we have about 6 total. Some are new, some are from last year. And you need to think about thresholds too, Chairman Foster, right? So you don't want to have these adjustments for small details. So there is another question. When do you want to make that adjustment? Is it 100,000 threshold? So you don't do any adjustment below that, or is it more than that? And that's another place where you could moderate those numbers as well.
Okay. All right. Thank you.
So that's kind of the I believe very important and a challenging question to balance: concerns for access, providing fixed cost revenue, and balancing the incentives for transformation. So there's a lot of decision points around service line changes, and what you have is what CMS proposed. We have not had extensive discussions around what the Vermont could do, but given the state priorities, I heard access is important, unintended consequences are important. So as we're thinking about these decision points, we will come back to you for further details. In general, here is kind of a summary. on the marker shifts, there is also small cells issues that, there is an algorithm, you can run it and see what it is, but given the size of the state and some hospitals, there might be some challenges just to algorithm and then see what that spits out. So unfortunately, I have to stop here. So we cover the service lines, and I'll be in touch in terms of the next meeting. Maybe we take these again and summarize the options and decision points, but I'll be in touch with Elena about the next, when I'm back with you, but obviously you can continue to have the discussion.
Great. Thank you very much, Ms. Garavich. We appreciate you coming today. Ms. Barabee, I forget if you had more or not today.
So what I was thinking we could do is I can kind of revisit some high level slides, and then if we wanted to spend some time talking on the adjustments that you've heard about to date. I know I recognize you haven't heard the whole thing and gotten into weeds on everything, but it might be good to shift over to discuss some of the negotiation, considerations that we have as it relates to this methodology and some of these adjustments. So if that feels like the right use of the rest of our time, that's what I would propose.
If we have time, I think we should use it, given all that we need to do.
Yeah. Okay. So what I will do is I will share my screen. So it's the same slides. I've just reordered them, given our unique challenges today. Let me know when you can see.
That's up.
Okay, great. So, you know where we are, May 1st, we're just continuing. It's been really challenging to kind of get through the material, but this kind of pushes us out a little bit. We still need to get through, I think, some of the performance adjustments. We made some good progress today, but we also want to kind of come back together on Monday and talk about the critical access specific considerations in more detail. Given, the rural nature of some of our hospitals and volume considerations. And then the hospital transformation funding, the Vermont specific adjustment related to that, it would be good to circle back on that as well. But we're all working towards kind of a vote for June 1st. But I did want to kind of show this slide again on what it is that we're voting on. So today we've been talking about all the different components of a methodology that would allow us to develop kind of the specification or the manual for calculating a Vermont-based or Vermont-specific Medicare hospital global payment. And we would need to vote on that by June 1st on the methodology component so that we could then create a specification. So that's kind of the detailed under the hood codes and hand it over to Medicare. They would need to be able to understand and calculate that. But that said, so that needs to go to them by July 1st. The methodology would not necessarily be final. There's still a lot of negotiations that would have to happen. They would need to review the methodology and the specification. And then there are a lot of other components that kind of intersect with this work. And then the next time you would kind of weigh in would be during the vote on participation in the AHEAD model, June 30th, 2025. Any questions on that or the timeline?
Just one, which is, we all really value the public comment and feedback. So like on the negotiation, we're going to have a model. We're going to discuss it. Is the model, Robin, maybe but the model that we propose, the methodology, if we propose one, is that going to be public and receive public comment? I know it's received tag input as we've gone.
Yeah, I think what, and Elena should feel free to chime in. I think what we have been talking about is putting the methods paper out for public comment as a more accessible document potentially than the weedy specification. But I think the spec could also be a public document as well once it's submitted. And certainly folks can provide input even after it's submitted, given the negotiation will take some time.
Okay, thanks.
Great. Okay, and we talked about that last time. So this is a summary. This is more for your reference, a summary of all the adjustments. And I sent to the board, and it's posted on Medicare's website. There is a specification document for the Medicare kind of off-the-shelf calculation, and you can kind of look at some of the definitions. As Shule mentioned, there might be some missing pieces, and it may not correlate directly to some of the things we're talking about, but there's a lot of great information there for those folks who are interested in the weedy nuts and bolts of what they put out there. And oh, I'm going the wrong way now. Wow. Okay. So I wanted to briefly talk about next steps. I think, it's 5/1. This was developed last week. So these dates are gonna might have to shift a little into next week, but we expect a full draft. Hopefully, initially it was scheduled for May 15th, so we might have to be a little flexible, given that we're still kind of getting through the material. Staff are also working to outline kind of future analytic work that would need to happen to evaluate kind of the broader scope of this methodology paired with what we're learning through negotiations. So again, this is the start to something rather than the final product. So I just wanted to remind folks of that. I don't know if you want to stop for public comment here, but my goal is to kind of transition to those more negotiation level questions for board discussion.
Let's do public comment so people don't have to wait around if we go into executive session. So I found this discussion really valuable and helpful, and I hope others did. And I'd love to hear any public comment if folks have any. Mr. Del Trecco, how are you?
Good. Thank you for this meeting today, Chair Foster and board and Elena. And even though Shuli's not here, I know there's a lot of work going into this. I think as we move forward, we need to have some of these, the questions I thought were fascinating, and the amount of information supporting them seems a little bit less obvious at times than others. And how do we improve that as we move forward? And I think one of the things that our hospitals would want to see is, what does each organization's model potentially look like? And how do we evaluate that as we move forward? As I try to compare and contrast the Medicare model to the state model, there's not a whole lot of, to me, substantial difference. There are certainly some areas of transformation that we're looking at, but those are some other things that I think are challenging. And this is sort of the first pass at all of this information, so it's a lot to take in and look at and listen to and try to understand. So we'll keep looking at this slide deck and working through our thoughts. But one is, how and when could hospitals understand and see what this might look like? The conversation around service lines was fascinating to me. Hospitals don't do strategic planning monthly, weekly, and I know those weren't the timelines, but they do strategic planning every 3 years. And how nimble is that process on service line analysis, service line movement? One of the things where we have a lot of migration potentially outside of the state, one of the notes on one of the slides was only if it's within the state, but what happens if you pull service lines from out of state? Does that adjust the model? So I have tons and tons of questions. I think that's the baseline of my comment. Lots of questions. Lots of work has gone into this, and there's, directionally, I think there's some opportunity that we should explore, but lots of questions outstanding.
Yeah, thank you. Thank you for coming and commenting. And just for other folks, we are going to have some providers speak on the 15th of May and about their views and questions. And then we'll make sure we get VAHs and any hospitals that want to participate in any hearings for sure. Mr. Del Trecco and I have a really open relationship and line of communication, as he does with AHS. And I guess I would just publicly say I appreciate that on this topic and all topics, but this topic very, 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 very much. You can probably see board members struggling with even knowing what the right questions are to ask at times, and we're not hospital executives. And so that input from your organization and your expertise and your members' expertise on what the questions should be, incredibly important here. So please, I'm solicitous of that, and we thank you for doing it.
Yeah, I appreciate that. And, you know, the vote on June 1st is, if I thank you for that slide, and for clarification, that's about, should we explore moving forward with a Vermont model under these parameters, even with the questions that we have? And I think part of evaluating that is, do we think there's an opportunity here that could improve all of the things that we struggle with, affordability, access, and because I don't know that I'll have all the questions either. And I don't think, even if we thought we had all the questions, we would even have remotely the answers. So I'm looking at it baseline. Is this an opportunity for us to explore and move forward with that exploration as we try to determine the questions, the answers? And, you know, CMMI often can be, you know, hearing the information second, third hand is sometimes challenging.
Thank you. Mr. Davis?
Thank you, Mr. Chairman. This is obviously a complex area, and you and some other board members have gone beyond what most people could do, just by your question to demonstrate how difficult it is. We're going to look at this in the future. So I would just ask you to just keep in the back of your mind what I think is some possible unintended consequences. Number one, the first is, does somebody really expect regulators, even terrific regulators, to understand how to run hospitals? Does anybody really think that? I don't care how good you are. You've never run a hospital, and then running hospitals is really complicated. Secondly, what I would say is that I think a real risk here is that recruiting doctors, getting good doctors to come to Vermont is not necessarily easy. It's cold, and it is small, and there's not a ton of money here. There's not much money here. Okay, and if one of the things I worry about is if just listening to the questions and listening to the presentations, is if you're a really good doc coming out of Hopkins or UW Seattle or Yale New Haven or whatever, okay, do you really want to come to to Vermont, okay, to a place where they're gonna the doctor would actually have to start reading those these slides that are coming out here? It could scare them to death. And if you think that isn't a problem, it is a problem. And so I would just watch out for that. I think this is incredibly risky to go to dive into a thing of this enormous complexity. I think there's better ways to do it. And the third thing I would say is that one of the things I think in the real political world that will happen is, if you go to global budgets, but boom, what you've done is you've locked in the structure that you have. Now, what we've got is 14 hospitals, with a little over 600,000 people. I don't think any sentient policy analyst would think that you really did need 14 full service hospitals, plus a very good academic medical center that is a stone's throw across the Connecticut River, okay, and which provides pretty much all of the tertiary care for the East Coast. So this is just, I think it's a really risky thing. I wish you luck. Thank you.
Thank you very much. Yeah, and that is one of your last comment is really relevant to the transformation work that's undergoing right now and how this lines up and disincentivizes or delays or promotes or whatever it might be. Because I think, obviously, as we mentioned earlier, the board really supported that transformation work that's underway right now, and it's a huge priority for us. So thinking about the timing and the sequencing and how that all fits is another puzzle piece on this to the other ones that you cited, which I think were really fair. And in terms of the risk, the system seems really in a tough spot, and we want to make smart, bold decisions that help the system. But you're right, there's a lot of risk given the difficult financial margins for hospitals right now and insurance companies and everyone else. So thank you for the comments. I see no others at this time. So Ms. Barabee, you wanted to transition to an executive session?
Yes, let me get my slides back up. Okay. Do I need to revisit? I think these are the same grounds that we discussed last time. We were discussing the global payment for contracts, but you have to make a specific finding that the premature general public knowledge would clearly place the GMCB or person involved at substantial disadvantage. And we have motion language and a vote, so you need 2/3. So I'll put this up from last time. It is the same conversation. We're just kind of moving through the adjustments.
Well, I'll go ahead and move. I support going to an executive session given the sensitivities around our negotiation strategy with CMS. So I move we find that premature general public knowledge regarding negotiation of Medicare total cost of care target and hospital global budget proposals would clearly place the board at a substantial disadvantage in future negotiations of contracts with CMS that includes those items.
I'll second.
All in favor, please say aye.
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 Aye. I also move that we enter into executive session to consider negotiation of Medicare total cost of care target and the hospital global budget proposals under the provisions of 1 VSA 313A1A of the Vermont statutes. Attendance at the executive session will be the board members, board staff working on the agreement with CMS, board contractors from Mathematica working with the board on the agreement, and the state's director of healthcare reform and other staff from the Agency of Human Services working on the agreement.
I'll second.
All in favor, say aye.
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 Aye. So we will move to executive session. I'm going to take it's going to take me 2 minutes to switch over. And if the public wants to leave, I think we're going to finish in the executive session. So there probably won't be too much after this. All right. Thank you.